Good evening, I'm Andrew Chang. Adrian is away. Tonight, billions of federal dollars announced to reopen the country safely.
We're not sure what the new normal is, but this money's going to help us get there.
From childcare to transit to cities, is it enough to get Canadians back to work?
You also worry that there could be potential tampering activities.
Russia is accused of hacking into COVID-19 vaccine research, including Canada's.
Did you discuss this matter with any member of the Prime Minister's office?
The opposition grills the minister responsible for the We charity contract. And our national conversation about medical assistance in dying.
We still live in a country where the vast majority of Canadians do not have access to palliative care.
Canadian questions about the challenges, the ethics, and the law. This is The National. To try to contain the coronavirus, Canada shut down huge swaths of its economy. But opening them up again and recovering, that's a whole other challenge. Today, that effort got a multi-billion-dollar boost from Ottawa. An agreement struck between the federal government and the provinces and territories to provide crucial funding for some key areas. Think transit, childcare, and municipal governments. The Safe Reopening Agreement has taken weeks to negotiate, and in the end, it amounts to more than was previously promised. David Cochran with the details and the reaction.
It's a big agreement to tackle a big problem, the safe reopening of society before there's a vaccine.
Our government will invest over $19 billion to ensure the provinces and territories have the support they need.
There's billions to expand testing, contact tracing, and stockpile PPE. More money to protect seniors in care, and more overall for the health system, specifically mental health, addiction, and homelessness.
But COVID-19 isn't just a health crisis, it's an economic crisis, too.
So $625 million to create childcare spaces so parents, mostly women, can go back to work. And a $1 billion sick leave program, up to 10 days paid leave for people who don't have it.
The cost has been far in excess of $19 billion across this nation, but this goes a great way to acknowledging some of that existing cost that has already occurred and the cost that has yet to occur.
We are going to continue working with the provinces and territories. We're going to continue working with the municipalities.
Ottawa cut the deal with the premiers, but it trickles down to cities and towns who have been crying out for help.
I just think it'll help us with a wide range of our problems and will hopefully go a long way to making sure that the kinds of cuts or tax increases that had been discussed will be minimized or perhaps eliminated.
To do that, there's $2 billion to cover municipal operating costs, $1.8 billion for struggling public transit. The premiers have agreed to match that dollar for dollar. This agreement will run for 6 to 8 months. At that point, the money will be gone, but the virus might not. And the negotiations will start all over again. David Cochran, CBC News, Ottawa.
Now, the economic restart means getting people to work. And two key elements there are transit and childcare. Carolyn Dunn shows us how today's promise of funding for both is panning out in Canadian cities.
It's no longer a question of how to keep transit running on time, it's how to keep it running at all.
People need to commute to work, they need to go see their family, they need to go see their friends.
But the money raised from transit fares across the country has plummeted. Unemployment and working from home is costing the Toronto Transit Commission hundreds of millions of dollars. So today's announcement helps.
I am thrilled with the federal and provincial announcements about the money coming. I'm really looking forward to the details, but it'll help the TTC and the City of Toronto as a whole. We're not sure what the new normal is, but this money's going to help us get there.
Passengers can see it's a no-brainer to get the economy back on track.
We want people to get back to work, right? So I think that they're going to have to try and maybe reallocate funds, so that people that do need to rely on the subway, that it doesn't become, that cost is not passed on to the consumer.
Calgary's mayor says transit and childcare are going to be key to economic recovery.
So for a lot of parents, they're actually being asked to choose a very horrible choice. You can have a kid or you can have a job. And for our economy to work, we need people to be able to participate in the workforce. And that means that people are going to be able to have access to childcare.
At this daycare, they've put in all the COVID-19 safety measures. Now they just need the kids. The daycare takes up to 180 children, but only 42 are enrolled, most of them part-time. Its director hopes the federal restart money will amount to a per-child subsidy.
I think daycares need the most help, because that is the first step to run the economy. First step is like children will go to daycares and then parents can go to work.
That's the plan anyway. Now everyone affected will be waiting for the details. Carolyn Dunn, CBC News, Calgary.
Quebec has recorded its highest number of COVID-19 cases since late June. 142 new infections were identified today, with at least 45 being tied to recently opened bars in Montreal. People who've gone, and staff too, were urged to get tested, which has led to long lines and a scramble to open new testing facilities. The province says it's not ruling out shutting down bars if numbers continue to rise.
This outbreak is a reminder that the virus has not gone away, and once it starts to spread, it can spread quickly.
Saskatchewan announced 42 new cases today. That's their highest one-day total yet. 31 connected to a growing outbreak in southern Hutterite communities. Alberta saw 120 new infections today. That's its highest one-day tally in 2.5 months. There's a surge of 70 new cases in Calgary, with several outbreaks linked to spin studios and restaurants. And CBC News has confirmed that the COVID-19 outbreak that triggered a so-called full facility closure at an Edmonton hospital is still growing. Of the now 53 cases at Misericordia Community Hospital, 17 emerged after it closed its doors to new patients last week. Now, there's only one way the threat from COVID-19 truly subsides: a vaccine. Research into that holy grail is highly prized. And now the US, UK, and Canada are openly accusing state-backed hackers of trying to steal it. Christine Birak brings us the case of vaccine espionage, courtesy of Cozy Bear.
It's no secret countries spy on each other, but calling it out is rare. In a coordinated statement, Canada, the United States, and the UK blasted Russia, saying hackers have been trying to steal information on the development and testing of COVID-19 vaccines.
We're all trying to find a vaccine that both our people and people around the world can benefit from. To have the Russian government engaged in that endeavour, I think needs calling out, and I think the world should know it.
Cyber attacks targeting universities and pharmaceutical companies were linked to a group called APT29, or Cozy Bear. Officials say it's almost certainly operating as part of Russian intelligence services.
We remain concerned, and not just the Russians targeting it, but other foreign actors as well.
Vaccine developers we spoke with say they're aware of the cyber threats and are constantly upgrading their IT systems to guard against them. Intelligence officials wouldn't say whether the hackers were successful or what they were looking for, but security experts have some ideas.
It could be a range of activities, everything from just stealing the information to use in their own research. You also worry that there could be potential tampering activities.
Russian state television recently reported the country has a vaccine going into stage 3 clinical trials. While there's national pride and lots of money at stake in the vaccine race,
there's no way of saying that criminal behavior by the Russians is justified.
Some experts say there's also distrust around who will get access.
There is honest anxiety of whether a vaccine will be available for everyone.
And with the health, economic, and political stakes for the vaccine this high, clearly some nations don't want to rely on the goodwill of others to get a hold of it. Christine Birak, CBC News, Toronto.
A federal judge says Canada's spy agency has given funds to known perpetrators of terrorism to gain intelligence and then presented that information in court to get warrants without disclosing it had been illegally obtained.
I think clearly there needs to be greater candor. The courts have identified that.
The government agreed to order a full review of CSIS activities after the judge's ruling said the agency seemed to have a cavalier attitude toward the rule of law. CSIS Director David Vigneault said Canada's allies commonly pay extremists to obtain vital information. Opposition MPs questioned a Liberal minister today on choosing the We charity to administer a $900 million student grants program, despite its financial ties to relatives of the Prime Minister and the Finance Minister.
Were you aware of the family links between the Trudeau family and We and the Morneau family and We?
My focus was really on making sure that there was an additional support for young Canadians, for students.
That's not the question.
And that's
the question,
why
were
it
you
was
aware?
part.
At $5,000 maximum per position brings us to $100 million. Where does the other $800 million go?
Okay, so Vashi Kapelos is host of Power and Politics. Vashi, what caught your attention from today's questioning?
Well, the testimony, Andrew, was long, more than 3 hours, and sometimes very dense, but there was a significant piece of information to come out of it, and it came from the senior bureaucrat in charge of the student grant program. She told MPs that the We charity had actually come to the government with a proposal for a student volunteer program and talked to them about such a program or a version of it on April 19th. So why is that important? Because the federal government announced the grant program after that on the 22nd, and later that same day, we submitted an updated proposal that met the Fed's requirement for the program. And that directly impacts the Prime Minister's central contention that the Public Service told him and his cabinet the We charity was the only one that could run this program.
So what does that mean then about where this goes from here?
Well, we got some clues today. When the revelation was made in committee, for example, Andrew, you could audibly hear an opposition MP gasp. This will provide oxygen to their criticism of the government on this issue, and you can expect it to keep the controversy alive, though for exactly how long, I'm not sure. The committee that met today isn't done meeting in their probe of the issue either. They've got more meetings scheduled, and another committee, the Ethics Committee, well, it begins its probe tomorrow. So for now, the story continues, and the Prime Minister will likely find himself facing questions on the controversy for a time to come. Andrew?
Vashi, thanks very much. With COVID-19, it's hard to look south of the border and not get a sinking feeling. The U.S. discovered more than 66,000 new cases yesterday, continuing a weeks-long trend. And this can't easily be blamed on testing. As Canada boosted testing, the positivity rate dropped. But in the U.S., it swelled, suggesting the epidemic is growing. Yet, there's no unified response. Today alone, Arkansas and Colorado announced orders for mandatory mask use, while Georgia specifically banned local officials from doing the same. Now, amid the confusion, Wall Street took a hit today, too. As Salima Shivji tells us, it came on the word that new claims for unemployment benefits surpassed 1 million for the 17th straight week.
A neighborhood much changed. Several restaurants abandoned by their owners. The harsh reality of the pandemic keeping diners away. This taco place is yet another casualty on its last days.
The longer it goes, the harder it is for a lot of small and local places.
I mean, honestly, I'm kind of shocked that they weren't able to make it.
That struggle felt keenly in the eyeglass business. 2020 was supposed to be a big year for Wagner Opticians, a small business Diana Finisi's late father opened 50 years ago. But they didn't make it past May.
I was probably 80% down in revenue and still tallying up all my bills with rent and trying to make payroll. And so the writing was on the wall.
More than 1 million Americans applied for unemployment last week, adding to a tally that's now at 50 million since mid-March. Some in states that are reverting to stricter lockdown measures are worried the help won't be nearly enough.
My business still hasn't picked up. COVID seems to be getting worse and not better.
Congress is divided over extending relief, with a $600 boost to unemployment set to end at the end of the month. And the Speaker of the House says that's just one part of the country's abysmal response to the pandemic.
Good morning.
Starting with the president's rhetoric.
He is like the man who refuses to ask for directions.
The president
refusing, too, to dwell on the virus spreading, preferring an economic message instead. Today, promoting deregulatory moves that Donald Trump boasts will be key to the economic recovery.
No administration in history has removed more red tape more quickly to rescue the economy.
That economic message track, a direct response to the polls that show Donald Trump's popularity is sinking, with no end in sight for a country fully in the grips of a pandemic. Salima Shivji, CBC News, Washington.
Now, Canada and many European countries may have had some recent success in bringing COVID-19 cases down, but globally, the pandemic is picking up speed. More than 13 million people worldwide have tested positive for COVID-19. The pace of new cases is now routinely more than 200,000 a day. The top three fastest growing hotspots are the US, Brazil, and India. The fourth is South Africa. And as Margaret Evans shows us, every day there brings fresh signs of disaster.
The storm is upon us. That's the message from the South African government to its people as COVID-19 spreads its pain across the country. Time, bought with an early lockdown in March, has caught up with South Africa. More than 10,000 infections reported every day now.
This is a fight to save every life, and we at the same time need to save every bed in our health facilities.
On Sunday, Cyril Ramaphosa reimposed a curfew and a ban on alcohol in a clear bid to slow the virus without shutting the economy down again.
We always knew that a lockdown for more than a few weeks was going to be unsustainable.
Epidemiologist Dr. Salim Abdul Karim leads the scientists advising the government.
We just have too many people working in the informal sector who are self-employed.
Social distancing is impossible in South Africa's cramped townships and informal settlements. Water and sanitation shared and often scarce. The picture is an uneven one, province to province, some coping better than others. In the Eastern Cape, the military has been sent in, conditions so bad in some hospitals that doctors and nurses are refusing to work there. Critics blame corruption, saying the pandemic has laid it bare.
I'm very, very worried. I think everyone should.
But for us to eat, to survive, what must we do?
The best we can, says Dr. Abdul Karim.
We're probably not going to have enough doctors, enough PPE, enough oxygen, enough of everything, because you can only prepare so much.
At a certain point, he says, you must simply turn and face the storm. Margaret Evans, CBC News, London.
Now, here in Canada, a snapshot of just how many people may have been infected and not known. The result of this country's first antibody study and questions about who is immune. And later, a special town hall about medical assistance in dying. Experts and the Justice Minister answer your questions.
Failed people like me. Will people with dementia be included?
From who is covered to how decisions are made and the bar patients need to meet.
I don't understand why you've made this a requirement.
The national conversation coming up. Welcome back. Quebec police say they have reason to believe Martin Carpentier is still alive. 8 days into their search, authorities say there are signs the 44-year-old stole items from a trailer in the densely wooded area they've been searching. Carpentier is wanted in connection with the deaths of his 2 young daughters, whose bodies were found Saturday. He's said to be in survival mode and may be looking for materials or food to stay alive.
We need federal intervention on the legal components of this in terms of decriminalization, and we also need a national plan, because although British Columbia is hit hard by this, we're not the only ones in the country.
A call for help today from John Horgan as BC marked another record month of overdose deaths. 175 people died in June. It's the province's second consecutive record-setting month of such deaths. Horgan says it's clear the drug crisis in BC is going in the wrong direction and more needs to be done. Well, now to the other health crisis in BC, and some good news. No new COVID-19 related deaths were reported today, but the results from a new study also had health officials pleased. It hasn't yet been peer-reviewed, but it shows the extent of infection in the province and how effectively the virus has been contained. CBC's Briar Stewart has the details.
BC has been praised for its flattening of the COVID curve, and scientists have a clearer picture of how few have been infected in the community. Their estimate, less than 1%.
Our snapshot was 2 months apart, right?
Dr. Danuta Skrovonsky led a team that tested hundreds of anonymous blood samples that were taken from testing labs in the Lower Mainland. They started testing in March when restrictions were being rolled out, and then tested hundreds more in May when things started to open up.
And what we found was about 8 times more infections likely than we captured by our surveillance reports. Now that might sound like a lot, but in fact it's in the same ballpark as other areas.
Which she says means BC isn't undercounting cases more than elsewhere. BC's infection rate is considerably lower than other jurisdictions that have done serological testing. In May, one study out of Spain estimated the infection rate was 5%. One in New York State found it was likely around 12.5%. In the coming days, there'll be an estimate around Canada's national infection rate. The Immunity Task Force is doing a much larger study. It's testing 40,000 samples of donated blood for COVID antibodies. Experts say these types of studies are helpful to gauge how areas are managing transmission.
It also helps at the moment because we still don't know the proportion of infections where people don't have symptoms or have mild symptoms.
But even once there's an estimate around how many have been infected, there are still unknowns.
And we don't yet know whether having these antibodies means that you're protected, that you're immune from this virus.
Considering that the vast majority here have never had the virus, health officials are reminding people that they're still at risk, and the infection rates can grow if they aren't careful. Briar Stewart, CBC News, Vancouver.
Okay, up next, we're bringing something a bit different. A special town hall with the Federal Minister of Justice.
You're still not giving the patient the ability to say for themselves, can I have a medically assisted death?
Answering Canadians' questions. Who has access to medical assistance in dying and who doesn't? The national conversation starts right after this. Welcome back. COVID-19 changed our lives, and it changed death in this country too. Medical assistance in dying, known as MAID, was affected. Some hospitals temporarily restricted services. PPE and physical distancing made procedures harder, and the presence of family members was limited. Now, these are all layers on what was already a very complex, deeply personal issue. Now, early this year, before the pandemic, we invited a group of Canadians to put their questions to a panel of experts, including the Minister of Justice, David Lametti, about who has access to MAID and who doesn't. Here now is the national conversation.
Today I'm feeling angry.
Today I'm feeling concerned.
Conflicted.
Hopeful.
This is complicated.
In the days and weeks and months before the COVID-19 pandemic hit, another public health discussion was happening in this country, one of life and death, specifically medical assistance in dying, or MAID. In the last 4 years, more than 13,000 people have chosen to end their lives that way. But it affects so many more. When a Quebec court decision forced the federal government to change the law, it launched online consultations back in January. And in 2 weeks, more than 300,000 Canadians responded. Part of what emerged, a list of proposed changes from the government affecting who is eligible and when.
We are talking about people who are suffering.
To qualify for medical assistance in dying, a person would still need to be suffering from a serious, incurable illness, disease, or disability, but no longer would their death otherwise need to be reasonably foreseeable, and no longer would they always have to give final consent at the moment their life is to end, which was a worry for those who feared they might lose that ability as their illness got worse and worse.
We must act responsibly and, most importantly, with compassion.
The legislation is now before Parliament, and a full review of the law was scheduled for June. When the pandemic hit, that review moved to December. But still, Canadians continue to have questions.
I need to ask this.
This is difficult.
This is complicated.
This is personal.
And in March, we put those questions to the experts as part of the national conversation. Joining me today, Federal Justice Minister David Lametti. Trudeau Lemons is a bioethics expert and law professor at the University of Toronto. Dr. Madeleine Lee is a psychiatrist working in end-of-life care. And Susan Desjardins is with Dying with Dignity. That's a patient rights group. Thank you to all of you for being here. Let's get to our first question. Judy, the floor is yours.
I watched my mother die a slow, painful death. My brother and I were the power of attorneys, and we were able to stop food, stop water, stop her oxygen, but I couldn't stop her suffering. So my question is, will or when will the MAID be available to a power of attorney to make those decisions?
Thank you for the question. I understand what you went through, having gone through a similar thing with my mother. Power of attorney is delegating decision-making, and that's something that we will look at with respect to advance requests in the summer review, and looking at, in particular, situations of cognitive mental decline, like dementia. For the time being, the law focuses on the individual's consent, so the individual making a choice. We still aren't at the stage where power of attorney will be able to be used, but it is something that could be considered down the road as part of that larger review.
Why is it any different where a person can make the choice to withdraw life support versus making the choice to administer MAID? They accomplish the same thing, except one is slower and one is more
ends
painful.
suffering and one doesn't.
Right.
One extends it.
I think we're all trying to eliminate or reduce suffering where we can, and I think that's one of the things that's certainly motivating me in pushing forth this legislation. There have been a number of traditional medical doctrines and religious doctrines too that distinguish between withdrawing treatment or withholding treatment under certain circumstances and actually actively doing something to end a person's life. And so these are ethically charged issues. These are, they're complex. And so these are questions we will look at, but they're not easy. They're really not easy.
Judy, thanks very much for your question. Appreciate it. Our next question comes from Justine Noel. I want you to have a look at this.
Hi, my name is Justine Noel. I'm 29 years old, and I would be looking to access medical assistance in dying at some point in the near future, if I'm approved. I've lived with chronic pain my whole life, but it really got debilitating around 18, at which point the idea of fibromyalgia started getting floated around by doctors. I can't work, I can't have fun, I can't barely leave the house. So far I've had 3 MAID assessments. The first 2 were denials, and the third one is pending an official answer. None of them were experts in my condition. I haven't met any fibromyalgia specialists who support MAID for fibro patients, because the people who spent their whole lives working on this, what they're gonna say is just keep waiting. Just keep waiting for a cure to be invented. But I can't wait for much longer.
Justine can't be here today, but her partner, Jason, is here in her stead on her behalf. Jason, thank you for being here.
Thank you.
What's your question?
What do you intend to do when there is not a MAID assessor who is an expert in the patient's condition?
So thank you, Jason. Thank you, Justine. The question is a good one, and I'm glad you asked it. The expert assessment is not, we're not requiring a specialist. We heard from people in the consultations, particularly from remote communities, that felt this might become a barrier if we required a specialist. So rather, it is somebody with some level of expertise in the condition. You know, there are 2 medical assessors who are looking into the file. Hopefully one of them will have access to a network of people. Again, it doesn't have to be a specialist.
Jason, it seems like you want to...
Yeah, I'm sorry. I don't want to be rude or interrupt. Yeah. From my perspective, I think the best expert in a patient's condition is the patient. And to put the decision on the shoulders of someone who doesn't necessarily have a thorough knowledge of their medical background or the suffering that this person has gone through, I don't understand why you've made this a requirement.
Madeline, maybe if I could have you weigh in on that. I mean, in practice, do you see this as being such an onerous requirement that it actually ends up hindering the process?
I was glad to have it clarified that it is expertise and not a specialist.
that's required, because I think that would be onerous and a real barrier if you required a specialist to be a MAID assessor. So for something like fibromyalgia, there isn't even really a specialist that you can name. The fibromyalgia patients often have rheumatologists and psychiatrists and neurologists and pain specialists, multiple doctors involved. So who is the expert in that?
Well, my perspective is that with this criteria, even with the proposed amendments, you're still not giving the patient the ability to say for themselves, can I have a medically assisted death? The government is still saying, well, hold up, no, you can't.
But there is a reason for that. You have to understand that medical aid in dying is a radical departure from normal treatment. So it means the end of the existence of the person. If there are chances for the person who wants to have medical aid in dying to get better, we really want to explore that. There are significant case reports, for example, in the Netherlands, in complex diseases, where a second assessment by a MAID assessor specialized in the condition that the person had discovered that the person who had been suffering for 8 years was giving up on life, has a second assessment, reassesses the person and says there is a misdiagnosis. They found treatment, the person's desire for a MAID dropped.
I mean, I think what is abundantly clear here is that the balance that has to be struck is incredibly delicate, incredibly frustrating as well. I hear that, but Jason, we're gonna have to leave it there. Thank you very much for your question. Okay, do stay with us. We will have more questions right after the break. Welcome back. We're here in the National Studio taking questions about medical assistance in dying. Our next question comes from Ron. Tell them about yourself and what your question is.
I'm very pleased. I'm pleased to have this opportunity. It's an extraordinary chance for ordinary people in Canada to talk about a very serious issue. I have dementia. I was assessed 4 years ago. Unfortunately, Minister Lametti, when the bill came down in 2016, MAID was constructed to be a failure. And it failed people like me. Why did we limit or take out any consideration of people with dementia? We have 10 to 15 years in which I can make a decision as to when and how I want to die. Will people with dementia be included in this review we have coming up?
In 2016, when the first legislation came out, I was losing my mother to dementia. And so I understand the personal dimension of it. Yes, we were supposed to look at dementia, other forms of cognitive decline in the review.
Right, because when you talk about this particular bill, I mean, it's been expressly excluded. I mean, like people for whom their sole underlying medical condition is a mental illness. And a lot of people are asking the question, why?
We heard around the table again and again and again, particularly from MAID providers, medical health professionals, that we weren't ready yet as a society. Let's leave this complex question for the summer review.
We will have to leave that part of the conversation there, but Ron, thank you so much for your question. I really appreciate that. Thank you very much. Our next question comes from Glenn Johnson, who's here from Ottawa. Glenn, take it away.
Thank you, Andrew. I suffer from chronic pain, but I also have mental health issues and suffer from PTSD. Pain is pain, suffering is suffering. There's no foreseeable end to either of my chronic pain or mental health issues. Why are people like me not able to access MAID?
We know that mental health issues are serious medical issues and that the pain that's caused is serious, the suffering is intolerable. I think the short answer is we had meant to study this more deeply starting in June of this year. And we heard around the table that, particularly from medical health professionals, that it was so complex that we just weren't ready yet.
But it's also a right, a human right, and a right to choice.
I know that, and we're going to push pretty hard because of that. And we need to get to that answer as soon as we can.
I feel like the one answer you'd like to get is, so what's the timeline, right? When does this plight become the issue that gets solved in the forthcoming legislation?
Well, we're starting it right now, which is great. And one of the good things about the consultation that we've done now and the work we did in 2015, 2016 as well, it got people to begin to think about it. And society's come a long way with respect to mental health in the last decade. But I can't promise a timeline. I can only promise to do my best as long as I'm in this role to push this discussion forward.
Susan, where do you sit on this?
We are very concerned about the exclusion of individuals with mental illness. I'm glad to hear that that would be considered in the review, and I think it has to really be seriously considered because the rulings so far have made it very clear that you cannot exclude groups of people based on their diagnoses, and that could be found to be unconstitutional, infringing their rights, and further stigmatizing those individuals. So we really need to hear from individuals with lived experience, and we need to hear from professionals as well to determine how we can do appropriate assessments on a case-by-case basis where whatever their pain and suffering and condition may be.
Madeline, what is the way forward on this issue?
You know, I agree that suffering is suffering and that it contributes to stigmatization to exclude mental illness. But I also agree that it's extraordinarily challenging. How do we know whether a request is a rational request or is it partly driven for irrational motivations? How do we separate suicide from a mental illness from a rational request to die? It's been almost impossible to distinguish because they both have rational and irrational reasons for wanting to die. And what it's taken, I've got several case examples where what it's taken is them accepting treatment for the depression. And after the depression is cleared, it becomes clear to the provider what the basis of the request was. And I've had patients who changed their minds after and patients who didn't change their minds after. That's why we need the research.
Glenn, thank you so much for your question. I would like to take this opportunity, of course, just to remind all the folks who are listening to these stories being shared on very difficult subject matter that there is help if you feel that you need someone to talk to. It's out there. You can call or you can text Crisis Services Canada, or you can visit them online. Okay. Our next question comes from Sarah Jama. She's an organizer with the Disability Justice Network of Ontario. Sarah, you've got the mic.
Thank you for having me. I want to know, with the removal of the foreseeable death portion of MAID, how we will make sure that this access to MAID won't disproportionately impact Indigenous and racialized communities who feel as though they're not being structurally supported to live fully sustained lives. How are we going to make sure that these communities don't feel pressured to access MAID because they feel like burdens on the state?
Thank you, Sarah, for that question. The social determinants of a person's condition are critically important, and we heard that time and time again in the roundtables, including a roundtable specifically aimed at Indigenous people, Indigenous service providers. And so if MAID is going to work, it has to be a choice, an informed choice, and it has to be a choice amongst good alternatives, or at least amongst the least worst alternatives, in the sense that we need to work on the conditions in which people live, so that if they do make the decision to get MAID, it will be because it's the right decision.
I still don't really understand how you build into the legislation, build into the MAID infrastructure, some kind of way to mitigate this concern, that in lowering the barriers, you are perhaps opening the door to those who are most vulnerable. And maybe it is those folks who will disproportionately be asking for this.
So the International Rapporteur on the Rights of People with Disabilities just issued a report last week in which she stated explicitly, disability, chronic illness should never be a basis for facilitating, in other words, promoting by the state access to premature death. This is actually what the new law will do. And I see, as a scholar, that there are attempts to introduce safeguards in terms of that there has to be a 90-day waiting period, that physicians have to provide information about the available resources, and that they have to look at whether the person has seriously considered alternatives to having their lives ended. 90 days is nothing. to turn people's lives with a serious disability or a very chronic illness around.
Sarah, thanks so much for that. That was an excellent question. Cheers. Okay, when we come back, more of the national conversation. Do stay with us. Welcome back. I'm Andrew Chang, and this is the national conversation on medical assistance in dying. Let's get to our next question.
Hi, my name is Dr. Nahid Dasani.
How are you doing?
I work as a palliative care doctor. My practice especially focuses on communities who are vulnerable, including those who are homeless and countless more who are at risk of homelessness.
Our experience is that the homeless,
through a program called PEACH, Palliative Education and Care for the Homeless, a mobile, street and shelter-based palliative care program that puts our team on the front lines of the homelessness crisis and opioid overdose crisis. I'm particularly interested in today's discussion around equitable access to palliative care.
Immense work
Thank you.
that you do.
Thank you.
What's the question you'd like to ask?
While I appreciate the importance of discussing medical assistance in dying at this time also presents a unique opportunity to talk about the benefits of palliative care during all stages of an illness, not just at the end of life. And I do want to remind everyone in the room that the WHO has recognized palliative care as a human right, and we still live in a country where the vast majority of Canadians do not have access to palliative care.
I agree with you. We need more palliative care resources. But it's not, for MAID, it's not an either-or situation. It's actually both and. We know from the latest report out of the coroner's office, there was a paper recently published that showed 75% of people who receive MAID also were receiving palliative care. So it's not an either-or.
Trudeau, what are the
I
considerations?
think it's a question of prioritization. It's clear that the priority should be on the right to health care, the right to have access to adequate care. That medical aid in dying in any jurisdiction that introduced it, and there are not so many, that is seen as an exceptional measure to facilitate the transition between life and death. We're now expanding that in an area where decision-making is very complex. So all of this makes me concerned about, are we prioritizing indeed allowing people to live their life to the fullest possible with the best possible healthcare support, or are we seeing, for one reason or another, medical aid in dying as kind of a magical solution to suffering of life?
And Susan, I mean, this push and pull is core to everything you've considered.
Well, our mission is to improve the quality of dying, and that is not limited to assisted dying. It's improving quality of dying, including access to palliative care. And if I can be a little personal, I have had the opportunity to accompany a family member through treatment, and she had accompanied her spouse through ALS, and for years had said to me, I am not dying that way. So she had the opportunity to request an assisted death, and for her it was the right decision and the right choice, and gave her back some of that control over how her life ended, and made it a much better death for her and for those of us who accompanied her.
Thank you for your question. Thank you. There were many more questions on assisted dying from across the country, including these.
I was diagnosed 7 years ago with early onset Alzheimer's.
How many people living with disease are being included in your review?
What steps are being taken to offer protections for others who are vulnerable to all the psychological and emotional consequences of participating in a medically assisted death when it is against their conscience?
You can watch the full national conversation on CBC News Network this weekend. And I do hope you'll tune in. You'll hear more questions, but also the full range of answers from the panelists to the questions that you did hear. Okay, that does it for us. That's the National for this Thursday, July 16th. Have a good night.